Good afternoon, and welcome to the latest Facebook Live event hosted by the National Cancer Institute. My name is Dr. Leanne Bailey of the Center to Reduce Cancer Health Disparities Integrated Networks Branch. And I'm joined by Dr. Jim Zabora and Mr. Theron Scott from Johns Hopkins Center to Reduce Cancer Disparities. I welcome you to what promises to be a very interesting conversation about the present and future of colorectal cancer prevention and screening. If you like the information that's presented during this broadcast, please use the share button located underneath the video to share the information with a friend or a loved one. In addition to the topics that will be discussed in this broadcast, we've also provided links to NCI resources for your reference and how to connect to NCI's Cancer Information Service. If you have questions, please post them in the comments box below this video, and we'll try to answer as many as we can during this broadcast while we're live. Any questions that we don't get to will be answered afterward. The Center to Reduce Cancer Health Disparities is central to NCI's efforts to reduce the unequal burden of cancer in our society via basic and community research, as well as training the next generation of researchers from diverse populations in cancer and cancer health disparities. We also have programs like the Geographic Management of Cancer Health Disparities Program, or GMAP, that focuses on creating nationwide networks that support research infrastructure, collaboration, and training. The Center also supports the National Outreach Network, which is a multidisciplinary program that bridges efforts not only with cancer health disparities research, but also training programs. And our NON program conducts outreach and research activities through trained community health educators that are located at NON's partnering institutions at NCI-designated comprehensive cancer centers. Dr. Zabora and Mr. Theron are also actual CRCHD grantees, and we'll speak more in depth about their activities in the communities that they serve in just a few moments. I wanted to give you a little bit more of context about NON and the current initiative that we have, which is called Screen to Save. Screen to Save aims to increase colorectal cancer screening rates among men and women ages 50 and older from racially and ethnically diverse communities and in rural areas. The categorization or the top target priorities for these populations are American Indians and Alaskan Natives, Asians, Blacks, African Americans, Hispanics, Latinos, Native Hawaiians, and other Pacific Islanders. Through Screen to Save, community health educators funded by our NON-network and our Partnerships to Advance Cancer Health Equity, or PACHE programs, will provide culturally tailored, evidence-based colorectal cancer information, education, and screening resources that specifically address the needs of racially and ethnically diverse and rural communities nationwide. Our community health educators, or our CHEs, are at the center of all of our programs, and specifically these activities. Both of our guests today are CHEs who are out in the field in their communities, and we have over 50 CHEs nationwide dispersed geographically across the United States at comprehensive cancer centers that are engaging in activities and awareness and education around not only Screen to Save, but also other common cancers. So now, I'd like to start a conversation with Dr. Zabora and Mr. Scott, who are very experienced community health educators. So with that, I'm going to ask them to introduce themselves briefly and then talk a little bit about some of the work that is ongoing in the community. Mr. Theron Scott, would you like to kick us off?
Yes, my name is Theron Scott. I'm a Senior Research Program Coordinator at Johns Hopkins Center to Reduce Cancer Disparities. My main role there is to coordinate, conduct all educational and outreach activities within the community. Being a native Baltimorean, I have a complete overview, insight, connection to my city, and I'm able to be an ambassador from the university to the community.
And my name is Dr. Jim Zabora, and I'm the Director of Education and Outreach for the same Johns Hopkins Center to Reduce Cancer Disparities. And in my role, we do a lot of things in terms of evaluating educational materials, trying to determine exactly what we think will work in the community, But I think our important role is along the lines of building a presence in the community, because I think the more the community sees us, the more we can build interactions. Interactions lead to exchange of information, exchange of ideas, and out of that begins we develop a joint effort to really bring some action into the community about something such as important as colorectal cancer screening.
Great, thank you so much, and we're absolutely delighted to have you here for this conversation. So this discussion coincides with March, which is National Colorectal Cancer Awareness Month. And as some of you already know, one of the 10 recommendations from the Cancer Moonshot Task Force was to increase colorectal cancer screening. And so we are keenly aware that a one-size-fits-all approach is not adaptable or implementable in these communities. And so this is one of the reasons why NCI and CRCHD are specifically collaborating with partners nationwide around the Screen to Save initiative. We recognize that it's going to take partners at all levels in order to address this important disparity. So through the Screen to Save program, grantees throughout the country are mobilizing and coming together and really making education and awareness a priority in these communities that need it most. So I'd like to talk a little bit about community health educators and their role in the community, and more specifically, what it is that you do as a community health educator. You both alluded to it a little bit, but I'd really like to be able to hear from you what some of your activities are, what your target population is, and then we're going to have a more in-depth conversation about maybe some of the challenges that you face in dealing with these communities. So, Jim, would you like to start us off?
Sure. First of all, I think I see our role in thinking about all of this and colorectal cancer screening from a community health educator's perspective. I do what I normally do, and as I Googled what does a community health educator do, I thought I might get some interesting ideas. But what was surprising about, and this came from the U.S. Department of Labor, what became very interesting to me is they talked about being in organizations and clinics and so on, but I didn't get any sense from the job description about the level of interaction, planning, community involvement, and so on. There was nothing to me that really kind of showed the depth that you have to go into a community to really establish these relationships. I can just tell a brief story. The first time I stepped in East Baltimore was 1988, and we had just cared for, I was director of social work in the center, in the cancer center, and we had been called to the emergency room to care for someone or provide a treatment plan for someone that was brought to the center 6 blocks from our center, our cancer center, and she had a stage 4 breast tumor. And it was a tragic case, and the family was arriving, and it took us a good while to sort that out. And we went back to our cancer center and we sat down together as a staff and said, this should never happen again. What that led to was us developing from a cancer center perspective what we needed to do in terms of breast cancer screening. And we took that to the community in order to insert it into the community. And my first meeting was with Reverend Melvin Tuggle, Garden of Prayer Baptist Church. And I went and presented the idea to his executive committee because they were very much interested in health promotion. And he said, why are you here? And what I said that day was, I'm here to empower you and to help you develop and address this serious program that exists in East Baltimore. And he said to me, the meeting is adjourned. And he said, if you'd like to step outside, I'll explain it to you. So we went outside and he said, you can't empower me. I have the power. I determine whether or not you come into my neighborhood and into my community. Now, if you want to go back and we sit down and we look at this together and we plan what this program will look like together, then we have a partnership.
So I see that, to your point then, it's really a two-way dialogue. It's engaging and allowing, not even allowing, it's providing the opportunity for the community to provide feedback and then for you to respond accordingly. So it's more of cultural humility as opposed to you just coming in with a plan.
Right.
So, Mr. Scott, what do you think from a colorectal cancer standpoint? I mean, we've just heard, obviously, about a breast example, but with colorectal cancer being at the forefront and such a big problem in Baltimore, would you have any thoughts about that engagement?
Yeah, well, colorectal cancer being the second largest cancer killer is right in front of everyone. But a lot of times what we call, Jim alluded to it earlier about what we deem as outreach. A lot of time outreach is done within facilities. We take the outreach physically out to the people. We talk on the level of the people that we're speaking with. We have to rise with the PhDs, and we have to lower ourselves to someone whose educational level is not that large, because it's not about us looking good. It's about getting the topic, the communication from us to them on a level that they can receive it.
And I like the way you mentioned the word humility, because I really had not thought about that before today. And there are a number of community leaders in East Boulder who have said to me and said to Theron, we don't like the word outreach. That's your word. That's not necessarily our word, because outreach implies to us that it's a handout. I'm putting my hand down and saying, you can come to my colorectal cancer screening program. Well, we might not want to, because you didn't ask us about it, and we didn't have any input, and we'd like to have that opportunity. We know we can't run your program, but we can be actively involved in the messaging and the educational materials and so on.
Yeah, so I think that those are great points, because you really do have to ensure that it's a conversation with the community that's adaptable, that's fluid, and specifically addresses the needs of the population, whatever point in time they might be at.
Right.
So you've talked a little bit about some of the challenges, but there are many. And so one of the things that we'd really like to have the opportunity to explore here is how it is you cultivate that atmosphere or that relationship of trust, and how long that takes. I mean, Theron, you've been talking about the fact that, you're a native Baltimorean, and, Jim, you were a fairly new transplant, and the two of you in some cases look like an odd couple going into the community, right? So could you talk a little bit about your experience in that regard?
No, I think you're absolutely correct. And the presence in the community takes a while to develop that level of trust.
So how long does it take in for you?
I think, well, I've been back to Hopkins for a year. I'm back in early January of 2016, but I had been there for 20 years, from 1983 to 2002. So I went back, the first thing I did is I went back to reestablish all those contacts, because many of those organizations, churches, and schools and all were still there. So we have been spending time cultivating Theron's contacts, and I've gone in and say, well, what about Reverend Tuggle? Is he still here? Is Pastor Prentice still here? Can we reach out to them? Can we kind of expand our scope? And that's why we're hoping to do at least 120 community events this year, because we have that support from the organizations that are asking us not only to come in once, but then possibly to come back again in the course of the calendar year. And I think, well, I don't want to speak for Theron, but Theron can say, because I think Theron tailors the event to what are the needs of that organization in that neighborhood. So
It's truly relational. And some of the things that I've done is a little bit out of the box, like, say, for instance, you're talking about Johns Hopkins University, and it's looked upon as this big prestigious institution. But unfortunately, some of the population that we're trying to reach are the underserved individuals that are adjacent to the university. So what we try to do is, a lot of times we would take our time, like on Saturdays, and go to such and such church and help them with their cleanup activity or their picnic, and do some things when it's not recruiting or just teaching, and establish the relationship. And when they know we're vested into the community, it makes them more receptive to the messages we need to deliver.
So I think that gets to the question of why colorectal cancer screening and prevention is so important, and why we really have the opportunity to be impactful. So I was wondering if you could speak to that as well.
Because colorectal cancer is one of the cancers that we really can prevent. If we can get people to get screens, we can, hopefully you can have a clean colon. But what if you do have polyps? They can be clipped during the screen. It's not another opportunity, another occasion you'd have to come to the facility to take care of that. It can be handled right then and there. If we get our screens on it as directed, we should be able to prevent cancer. Most cancers, we don't have that same type of situation that we can deal with it. But with colorectal cancer, we should be able to do this. We need to encourage people to get their screens, get them timely, and stop getting stuck with these misinformation, misnomers, fears that is blocking people from getting their screens.
Yeah, so when you talk about misinformation and misnomers, Jim, can you comment a little bit on that as
Sure.
well?
Yeah, I feel like at times colorectal cancer is kind of the forgotten cancer up until just recently, and that's always because overall in the United States it's always sat fourth of the big four. So the focus has always been on lung cancer. We know about the women's movement in terms of bringing, and the Komen Foundation bringing breast cancer forward, and then the men finally got involved with us too and bringing prostate cancer. Well, nobody really advocated for colorectal cancer, and it's been sitting there as fourth in the United States, in incidence and mortality for years now. And it's exciting to finally say, here is a cancer that we can really prevent. I was in a meeting with Department of Health and Mental Hygiene, one of our partners, and they run one of the no-cost colonoscopy programs that we'll be working with. And I was talking to their coordinator, and I said, how many colonoscopies have you done? And she said, we've done 700. And I said, 700? That's incredible. I said, how many cancers have you found? She said, and she was very disappointed when she said this. She said, we haven't found any. And she was disappointed. And I said, well, wait a minute. 700 people, how many polyps did you take out of 700 people? So we're now talking to them about doing a project together to look at their data. And then along the way, we engaged MedStar Health System because they have another no-cost colonoscopy program. They've done 1,500 colonoscopies, but they have found 8 colon cancers. So we want to help them look at that data because I think if we can understand polyps and how many they took out per person and the fact that these people are surviving, we can take that data back into our messaging. And well, this is happening in Baltimore. This is not some national figure. This is right downtown where people are coming for these colonoscopies and look at what the benefit that's happening. So,
So one of the other issues I was wondering, Theron, if maybe you could speak to is the receptiveness of your target population to the actual screening itself and some of your experience with overcoming some of those barriers.
Well, one of the big things in the African American and Latino community, which we serve a lot, is they believe that particular screen, any screen that has to deal with entering the anus, has to deal with your manhood. It affects your manhood status. And it's been, and I'm not just talking about low level of education, I'm talking about widespread. And that in itself is a big barrier. But what happens is we're able to have people like myself who can walk them through the process, who can tell them what the process actually is instead of going with the information that's been shared incorrectly from their peers.
And then, Jim, can you speak a little bit to the misnomer or the inaccurate perception that going for the screening actually induces colorectal cancer as opposed to the opposite being true?
certainly it's that invasive nature of a colonoscopy, just like a digital rectal exam, that really causes a lot of concern among African American men. And they are our target population because they have the highest colorectal cancer mortality rate in Baltimore City. So that is our target for our project. And I kind of thought back as I was listening to Theron, one of our favorite or probably most productive ways to deal with this in prostate cancer was to think about the source of the message. Theron and I have different traits and characteristics and so on when we sit down with someone in East Baltimore. But at the same time, I know from my past training and so on that the message is very important. We have a great message, but the source of the message is probably the most important thing. And for us, we know, I know from my training, the source has to be knowledgeable, credible, trustworthy, and familiar. Now, together, we might be able to pull that off. But you bring in a Reverend Tuggle speaking on behalf to his congregation, and if he were to say something to the effect of, I am going for a colonoscopy and I want to know how many men would like to sign up to go after I go, it has a powerful effect. And he did that in one church sermon when we were doing prostate cancer screening, and he said, I'm going to be first in line on Saturday. I want 49 men behind me, and 48 men showed up.
Wow.
So we screened 49 men in about 2 hours' time, and he knew the 49th man that was missing. And he said, Jim, I assure you, he'll be here the next time. And he was. So we need those kinds of spokespersons to really kind of take our message with us and then without us as well, because they can be very powerful.
So I think that that's a great point to hit upon, and that, within the community there are gatekeepers and champions, and that's absolutely essential. But can you also speak a little bit to the need for coordination and for partners to be able to execute a lot of your activities? Because we understand that it really does take a village, and because of the fact that these communities are diverse and have different needs, all of those entities have to coordinate together to really be able to elevate the greater good, right?
Yes.
Well, I think between what I remember from my 20 years there, and I really did stay involved with Hopkins while I was away as a part-time faculty member, so I maintained some of those. But you take my old contacts with Theron's new and current contacts, it's enabled us to go, in my opinion, we can go anywhere in Baltimore City.
Yes.
Is the way we are known now. And that's taken time. Theron had really been building this over the last 7 or 8 years before I came back. So I've only known Theron since I got back in January 16th. But it's
Seems like forever.
Well, it does. Well, I mean, we just think alike. That's all it's doing. So sometimes he anticipates my thoughts, and sometimes I anticipate his. But we just sit down and we know Baltimore. That's the fundamental fact. And while I was born right outside of Baltimore City in southeast Baltimore County, I lived my life at Baltimore City Hospital growing up, because anytime I got injured, my parents would take me into the city to go to Baltimore City Hospital. So we know the city and we know where to go. And Theron has taken us everywhere, and he's been enabled us to create a great deal of respect.
And also to add to that, we firmly believe in community-based participatory research. And we have a community advisory group, Baltimoreans on their own time, that want to partner with us to help us with the perspective that you're alluding to. So besides for myself, we have input from all levels of research, all levels of grant writing, papers, the research, the community outreach, messages that we would give in a community. They've been able to tell us certain things that they believe would not go well in a community, and we followed their direction.
And you can take every principle of CBPR and apply it to community health education. And that's the way the program should be developed, according to those principles of CBPR.
Yeah, so we obviously at the center promote evidence-based methods, so on and so forth. But I think that because you've had such a long-standing involvement in the community, one thing that would be great to speak to is the role that technology has played and how it is you've been able to really disseminate your message. Because, traditionally it was flyers, it was really being out in the community, and not necessarily saying that that's changed, but being of the relatively new younger generation with social media and electronic communication, how has that impacted you?
Well, what we know from East Baltimore is that if there is a piece of social media that people use most often, it's Facebook. So we're hoping that today we have some viewers from East Baltimore, and I'm happy to wave to East Baltimore if you're out there. And we've partnered with the Johns Hopkins Urban Health Institute, because they have developed an interest in colorectal cancer as well. And they have developed, I think, 2 outstanding videos that are on YouTube, and we can provide those links. And but what was interesting is when they heard about us and we heard about them, this common interest in colorectal cancer, we came together, we invited them to our community advisory group. They presented their videos to our community advisory group, and our group critiqued them. They did critique them. And I warned them in advance that we have a very active group, a very experienced group, and they critiqued them, and the videos were edited and modified.
That's right.
But the end product is an excellent piece of film. It's an excellent message. One is an African-American male contemplating colorectal cancer screening. The other is an African-American female, because we're hoping to target both populations, both genders, and they came away with something that they're very satisfied with. So we'll be pushing those out into the community as well.
So in the advent of cell phones and smartphones, has that allowed you an advantage to be able to stay in communication and track the population, as well as just, I guess, engaging in community activities? Have you found that that is the new normal now with regard to communication, or is there a preferred medium that seems to work for you in Baltimore?
Well, you can touch it. My personal experience is hands-on. I think that hands-on, because some of the conversation that we have is so personal. There's directly eye-to-eye contact the hand-to-hand sit down. And it does, I know that it might seem more productive to get 100 people at one time. But if I'm speaking to 100 people at one time and not one of them get a screen, but I can take the time to speak to one person and that person does get a screen, then it was well worth it.
What we're thinking about is cell phones, because I think, in Theron, we had a vendor who was out in front of our offices, which is at the East Baltimore Medical Center on Eager Street, giving away free cell phones, doing a very, very productive level of sales. And Theron and I would sit there and would say, well, we know people are going to wind up with another cell phone bill. So is this getting a free cell phone, is this a real benefit to them, and so on? So we know there's a high rate of cell phone use. We're launching a smoking cessation study where it's going to be follow-up by way of cell phone in terms of supportive counseling. So we're moving in that direction for the first time, and that'll allow us to say, well, in terms of our work this year in colorectal cancer, is there something that we can use where it's built into the protocol? Because there's this very fine line about contacting someone that you've been in touch with to take information from them and do something without the IRB having some level of knowledge about that. So we want to move in that direction, but we have to be careful, so to speak.
I think that's an important point, and I think the biggest takeaway here is that it has to be really tailored. It has to be specific to the needs of the community, and sometimes cultural components play a role, but sometimes it's just real life also that needs to be taken into consideration. And I also like and appreciate your stories about not just visiting, but also going back and following up, right? So with the picnic, right, really doing the volunteer to demonstrate that you are committed.
Right. The cleanup, I'm aware of that one because that's Zeta House in Northwest Baltimore, and they have become one of our strongest partners. And it was just that extra little touch that really that Theron did that kind of really moved them towards us.
So that being said, we've talked a little bit about the fact that not everyone is amenable, if you will, to colonoscopy. So I'd like to take a little bit of an opportunity to talk about the fact that there are different types of screenings that are available depending upon to the receptiveness of your population. And so, of course, we always advocate that the best test is the one that's utilized. So to your point, it doesn't matter how many perhaps fit kits that you distribute or how many referrals you make. If the folks don't show up, then it's all for naught. So I was just wondering, Jim, if you could just take us through a few types of the screenings that are currently available. And then I also think we should talk a little bit about the risk factors as well, so that, if folks are not necessarily aware of some of the things that put you at increased risk, this is a great opportunity to share that information and to be able to follow up with your local provider.
Sure.
So, Jim, if you would.
I think there were two questions in there.
Yeah.
Hopefully I'll remember the second one. But anyway, in terms of screening, for most people that are between the ages of 50 and 75, and they're at average risk, there's no history in the family, there's no history of inflammatory bowel disease and so on, they can talk to their provider and they can get a fit kit or a fecal occult blood test that can be done in the privacy of their home and then returned to the provider or sent to a laboratory, for analysis and so on.
And that's not an invasive test?
Well, it's obviously it's taking a piece of a stool sample, but they're doing it in the privacy of their home, and it's not as uncomfortable or potentially embarrassing as a colonoscopy is.
Certainly.
Because we have documented through geocoded maps that about 6 blocks from where we are, we have a series of census tracts that have some of the highest colorectal cancer mortality rates in Baltimore City. We felt obligated to say we are going after those neighborhoods and those residents in those neighborhoods. So we have we have defined our project based on high risk. So we'll be presenting the concept of colonoscopy to pretty much everyone, because we feel when we step into those neighborhoods, we're going to see possibly having had a colonoscopy before, maybe had a polyp 2 or 3 removed and never returned for screening. We're probably going to find individuals that have 1 or 2 relatives that have a history of colon cancer or other cancers. So just by virtue of what we know about those neighborhoods from this geocoded mapping system, we also know, because just recently, about 2 weeks ago, we crossed it with a life expectancy map. That area also, the census block, which is a series of census tracts, also has one of the lowest life expectancies in Baltimore City. And it's 64, and if you moved maybe 4 miles to the north, it would be 84. So we're dealing with some neighborhoods where we know we have high poverty, high unemployment, a lot of other difficult issues. And that's what always makes our message even sometimes a greater obstacle to get to our message. Because when we started the prostate cancer screening program, we did focus groups all over Baltimore City, and I'm sure if we repeat it, we'd hear the same thing. And we asked residents for their top 5 concerns. It was crime, housing, unemployment, access to nutritional food, and the public school system for their children.
Wow.
No one would ever say cancer. Now, we know from previous studies from the Urban Health Institute and others that just the word cancer creates so much fear in the African American community that they don't feel why bother? There's nothing I can do about it, and I'm not going to survive anyway if I get it. Because there is so much cancer in the neighborhood. So we have a lot to kind of overcome and correct, and certainly there's some mythology going on there, and it may be not exaggeration, but overly concerned. And I think, we really need to be in those neighborhoods. So.
Darren, would you have anything to add to that?
Thank you. You hit it pretty good. One of the things that I think that we need to continue to do is just stay in the neighborhood ourselves, maintaining a presence and accepting someone's perspective as their reality. Because just because it doesn't make sense to me, it doesn't mean it's real to them. And trying to make someone change their perspective on a one-time visit is not generally going to happen.
Yes.
So will we be vested enough to partner with the people and walk with them and allow change to take place on their time, not just on our time?
And somebody once said to me in a community health education class, it's not what you say to me, it's what I think you said to me.
Yes.
So I always try to say, when I say something and the person appears to understand, I will always say, what do you think I said? What did it mean to you? Can you, in a sense, give me that feedback? Tell me what you think I said. Because I would say 50% of the time, my message was not heard as I intended it. So it has to be corrected.
That's a great point. So then just as a recap, let's just go through and just take an opportunity to talk about maybe some of the risk factors or things that might elevate.
That was your second question?
Yes, sir. Absolutely. You were paying attention.
But I warned you I might forget.
Did I finish it up?
Yeah, so let's just have a conversation. Given the high prevalence and incidence within these communities, are there risk factors or items that folks should be attuned to or tuned into?
It's probably the 4 risk factors that you see most often. Poor nutrition. Poor nutrition then leads to probably obesity. Certainly smoking, most often in East Baltimore when we're talking about our smoking program, individuals think we're only talking about lung cancer. Well, we try to explain to them, well, there is an aerodigestive tract where that smoke will travel, and we're not just talking about lung cancer because there can be a link. So if you're a heavy smoker, you could also be thinking about colon cancer. And then certainly heavy use of alcohol. And certainly when you're dealing with fairly underserved and poor neighborhoods, you can go through intersections in East Baltimore and there could be a bar on every corner. Every intersection has 4 bars. If not that, then there's advertising on the billboards on the sides of buildings. You can see 8 billboards in one intersection advertising cigarettes and alcohol. So we have some things to overcome.
And all of that wrapped up and coupled with low physical activity, eh?
Yes.
So it seems as though there are multiple messages that have to really be distributed in order to be impactful.
Right.
So those are the top 4 then that we've discussed. But also if you have a family history, that's also something that is not necessarily transparent and or shared readily in these communities. And so if you have a family history of colorectal cancer, if you have polyps or inflammatory bowel disease, disease, Lynch syndrome, your risk of developing colorectal cancer is increased. And so, of course, you should be in touch with your provider. We've provided guidance that the general screening age is 50. However, in areas, or if you actually, have any of these risk factors that are applicable, chances are it's not unconceivable to think that you should get screened sooner rather than later. And the other thing, too, is that race and ethnicity is also a factor. And so many doctors are recommending that African Americans start getting screened at 45.
Right.
And in other populations, so for example, with the American Indian, Alaska Natives, in some instances as early as 40. And so I think it's really important for you to have a dialogue. Again, I mentioned at the beginning of the broadcast that if you really find that any of these are directly applicable to you, that you share this information, that you really reach out and make an effort, because the best way to ensure and or treat cancer is to make sure that you never get it. And colorectal cancer is really one of the best cancers to detect early and have the best possible outcome from.
And prevent it.
Yes, no, absolutely.
Right.
So at this point, I wanted to see if you had anything to add with regard to the stigma of the screening or about cancer. I think, Jim, you spoke to that a little bit earlier.
I really want to emphasize this fear factor and the way it's perceived in communities like East Baltimore. And I recently went to a lecture from the Urban Health Institute where they presented their work, where they went out and interviewed 50 families from the neighborhood and just kind of accumulated those 50 family histories. And I was quite surprised by the level of cancer within these 50 families. They were kind of selected at random, not perfectly random, and they had two of the families were present and were up on stage, and the Urban Health Institute asked them, well, why don't you ever talk about cancer? And they said, in our family, we just have learned not to talk about cancer.
Wow.
And one of them said, well, Jim, what do you expect us to do? Sit around the Thanksgiving Day table and say, oh, by the way, let's have that annual cancer conversation. It's just not built in to kind of day-to-day living in East Baltimore, that it's extremely important that everyone know that family history, particularly from a cancer perspective, and what it is and who was affected and what those cancers were, how old were they when they were diagnosed, so they can put this composite together. So we really like the fact that in Screen to Save there's a nice table to kind of construct family history, and we hope to go use that and then go beyond it as well. But that, I think it's only by dealing with that and giving people the tools to sit down and how do you examine that as a family, and how do you look at it, and what do you do with it, I think then we can begin to deal with that stigma or that fear, because it just stops people from from moving forward or saying anything about the word cancer.
So that's a perfect segue at this point. We've reached almost the halfway point during our opportunity to have this conversation. And so we'd like to start to entertain some questions that have been coming in from our viewers. So the first question for the panel is, does health insurance pay for colorectal cancer screening?
In general, yes, but obviously not everybody has that level of coverage. And in the state of Maryland, we're fortunate, and a number of other states have done this too, have established programs through their state and local health departments to provide funding. In the state of Maryland, for example, when you complete your income tax every year, there's a little notation, would you like to make a contribution to the Maryland Cancer Fund of $2? And that's generated a lot of money within the state of Maryland that moves back into a treatment fund for those that can't afford something like a colonoscopy. Under the Cigarette Restitution Fund, because the state of Maryland was one of the very first states to actually sue the tobacco companies and win, and they won a $4.4 billion settlement, a lot of that money went back into research and treatment and prevention. So there are funds through the state of Maryland that we know very well because we interact with them all the time, in terms of have someone who has no insurance, doesn't want to apply for insurance, whatever the reason, we can get them into the state fund and they can get a colonoscopy at no cost. If they're positive for treatment, then the state also has a treatment fund available as well. So we're fortunate to have those kinds of resources that we can partner with on a day-to-day basis.
Yeah, so that's a great follow-up, because the next question says, what happens if a colorectal cancer screening test finds an abnormality? So Theron, would you like to speak to that?
Well, like Jim already alluded to, if your insurance does, you do not have the insurance to take care of it, then the screening is covered, and then on a piecemeal basis, we would deal with getting you the services needed, covering the services you need to follow up on that.
And with a colonoscopy, I mean, everything has a consent form in medicine these days. I mean, it's explained to you that during the procedure, given my history of colonoscopies, I know the procedure well, and people, you are told very clearly that if any abnormality is found, such as a polyp or potentially a precancerous polyp that they're concerned about that might be developing into an adenoma, it's coming out during the procedure.
Right.
So I remember waking up for the first time and they said, Jim, you had 3 polyps and they're all removed and we're sending them for biopsy. Now that was a pretty anxious 3 or 4 days, but at the same time, at the end of 3 days, I knew those polyps were negative. So I'm on a different screening process, and we just encountered someone on Saturday at this big event that we did with Susie's Cause, which is a national colorectal cancer foundation. And I was talking to a gentleman, and he said, "Yeah, I just had a colonoscopy, and they took out 3 polyps." And I said, "So you're on the 3-year program now?" And he said, "Yeah, I'm on the 3 program. Not looking forward to it." I said, "But sir, you need to do it." I said, "I'm on that same program with you, and we just need to keep going because that's going to prevent you from getting colon cancer."
Great. So if I can just summarize what you said, then if in the instance that an abnormality is detected, you follow up with a care provider of some kind in order to find out what treatment is most applicable for you.
Right.
And colonoscopy is most advantageous in that regard, because while they're already going in to screen and check and make sure that you're cancer-free, should a polyp be found, then it can be removed at the same time. So you can address the issue all at one appointment as opposed to a series of follow-ups. Is that correct?
Yes, because with the additional test that Jim alluded to, it still will have to, if something was found, you still will have to go to the colonoscopy because that is the gold standard.
Great. So another question that we have is, can you explain Lynch syndrome and how it increases your risk of colorectal cancer?
Well, it is a genetic mutation. It is definitely a gene that you can be tested for to find out if you have Lynch syndrome. It certainly is strongly associated with the development of adenomas within the colon, and it is also associated with a very high risk of those adenomas converting into colon cancer. I think, and this is based on memory, that Lynch syndrome is probably related to about 3 out of every 100 colon cancer diagnoses. So it's not high, but the probability of you developing colon cancer if you're positive for that gene and you have Lynch syndrome is much higher than the average person.
Right, so the genetic deficiency or dysregulation, if you will, contributes to the potential of colorectal cancer actually developing. And it is applicable not only to colorectal cancer, but to also other cancers such as endometrial, so on and so forth. And so,
Cervical,
absolutely. And so the idea is that because of the fact that these genes don't function properly, your probability of getting cancer is increased. And again, that all depends upon your own genetic makeup, right? And the most important takeaway message here is that because of the fact that it is inherent to your genes, if you have a mutation in those genes, it's highly likely that others in your family have that as well. And so that's the reason why screening is so important, and that's the reason why the identification of whether or not you are a carrier of said gene mutation is so critical. So those are all great questions so far. So the next inquiry is about what is the role of obesity in colorectal cancer risk, and can exercise and diet reduce the risk?
Yes.
That's the short answer, huh?
Well, I mean, the problem is obesity is associated with other things such as foods that people eat on a day-to-day basis, lack of exercise, all the other risks that we talked about too. I wouldn't want to focus just on obesity without thinking about a healthy diet and exercise and all simultaneously, and then losing weight, which is absolutely critical, because all of these factors influence the way the colon processes food and so on, and you just increased your risk. So to me, obesity is just one factor that has to be dealt with simultaneously with those other factors. Because if you find someone who's obese, you're going to find probably very poor food intake or overeating, and you're probably going to see somebody who's pretty sedentary and not very active. So I think we need to take on the whole picture, so to speak, to be really effective with that individual.
Yeah, absolutely.
And we have to keep in mind, I think the latest statistic I heard, about 60% of the people in the United States are either overweight or obese. So this is not a small problem. This is a very
no pun intended.
Right, exactly.
So we have time for one last question. Unfortunately, our time is drawing to a close. And the question is, are there resources for finding hospitals and or clinicians who offer other screening tests besides the colonoscopy? And subsequent to that, how do you talk to your doctor about using one of these other options?
Man. Using one or the other. I'm assuming this person is thinking, I have someone that doesn't want a colonoscopy and I want to go to the FIT kit or something along those lines.
Or maybe something that's less invasive.
Well, the sigmoidoscopy and the barium enema are still kind of unpleasant procedures as well.
So I think I can address the first question,
Sure.
if you'll let me take a stab. So there are resources for finding hospitals and clinicians who offer other tests. Again, every state has a local state health office, Medicaid, Medicare plans. There are several places that do offer other screening tests. And to your point, FIT kits are frequently distributed. And a FIT kit is a fecal occult blood test, right, where you can basically go through, you provide a sample, you mail it, they do a routine screening to see if there's blood that's found in that stool sample, and then they follow up with you accordingly. Again, you need to, at some stage, likely have a colonoscopy if that's found to be a positive result, but it is an alternative for you to be able to basically screen yourself with regard to colorectal cancer risk. Again, you still need to follow up,
Right.
but that is maybe a second choice if colonoscopy, for whatever reason, turns out to not be ideal.
Right. I mean, if you're in the state of Maryland, if you just, and this would apply to any state, if you just Google the state of Maryland, and then when you got inside to their website, just type into their search cancer resources, you're probably going to begin to see everything at the state level, and anything that's happening at the city or county level is in one way feeding up to the state level. So I always start at the top, because then I can work my way down to the jurisdiction where I have someone that we need information about in terms of what resources might be available.
And how do you recommend talking or starting the conversation with your care provider about colonoscopy, about colorectal cancer screening, and maybe not wanting to have a colonoscopy, but still wanting to explore these other options?
Well, I remember when I wanted to initiate it, and I was 54 at the time. I put it off for 4 years, and I was getting a lot of messages from family members and so on, and I just went in, and I don't think there's an easier way to say it than other than I know I'm 54 now, I know I'm inside these guidelines, I'm not doing it. Tell me what you think. What should I be considering from you're my physician, you're my provider. Help me try to figure this out for myself. What is causing me to kind of delay this test? And we had a very frank discussion. I've been with him for a long time. I trust him. I was afraid to go home and tell my wife that I did not agree to get one because, obviously social support is absolutely critical here. Maybe a family member could go with the person to have that discussion. I think anything we can do to create those kinds of situations, I think are important. Maybe even a neighbor or a friend that might want to go to say, I'll go with you. And I'll just sit there and maybe I'll listen. And make sure I hear everything so we can talk about it afterwards. So.
There, would you have anything to add to that?
Yeah, well, since things can be sort of tabooish in the community, we've been trying to encourage, like the old African proverb, each one reach one. Stimulate the conversation. We talk to people everywhere, and just like there's a lot of people who have not gotten their colonoscopies, there are a lot of people in those communities that have gotten a colonoscopy, be it a negative or positive result. And what I was telling you, use that experience to share with someone else, and let's reach somebody else. And that domino effect can be the groundswell to bring about some change. So we can sit down and talk about basketball. Why can't we sit down and talk about our men's health? Because it's sort of taboo. You don't go into the men's barbershop or these arenas where the men is and talk about health. I know you ladies do a little bit more. But we want to talk about sports and things that are superficial. When we can have already experienced something. I know you have superficial things too. But we can take the opportunity at these men's gatherings, because there's something about when a woman's in the room, how we put this false bravado on, and we don't want to go there. But we should utilize that bonding of men to bring about some change, because if we don't take care of ourselves, then we won't be there for our wives and our children. We need to do it as a village, and so we need to stimulate conversation, be it at the barbershop, be it at the Thanksgiving table you alluded to, wherever. We need to start bringing these conversations up, because it is proven screening saves lives.
There's just one more fact, because Theron's right, because in 2001, prostate cancer was the leading cause of death among African American men in Baltimore City over the age of 30. And we were told African American men would not come in for prostate cancer screening. And we screened 1,049 men in 9 months.
Yes.
So building the messages, building that camaraderie, having men talk together about this, listening to how we need to present this information. I think the same can be true of colorectal cancer screening.
I want to thank both of you wholeheartedly for your contributions, for the dialogue, and your transparency and experience that you contributed, not only for my edification, but for also everyone who's participated that's been a viewer. I want to thank both of you for spending the time today, as well as for all the important work that you do in the community and the community that you serve. Greatly appreciated by not only NCI and CRCHD, but I'm sure the people who are there, because without you, in many instances, they don't have a voice. And this is the opportunity for us to help them find their voice and mobilize that and get screened so that we can prevent colorectal cancer.
Right. I just want to correct, the name of our city is Balmer, and it's spelled B-A-L-M-E-R.
Okay, I can't help it. I just can't help it on that. So that is all the time that we have today. We really hope that you've enjoyed this conversation and the dialogue, and that you've been able to take something away from it that you can share, that you can propagate the message, because this is National Colorectal Cancer Awareness Month. And to Theron's point, we want everyone to be around. We want everyone to be able to contribute, and we'd like to see longevity and cancer-free survival. So I'd like to remind viewers that this video will appear on both the National Cancer Institute Facebook page shortly, and it will also be on the YouTube channel as well. Thank you, and in order to keep our broadcast and our dialogue going, we're going to have the first ever Spanish-speaking Facebook Live conversation hosted by NCI on March 29th at 1:30 p.m. so that we can continue to, again, discuss additional colorectal cancer issues, solutions, and next steps. So more details are going to be available on www.cancer.gov by searching for social media events. So with that, I'm going to sign off. And again, thank you so much, and we appreciate your time.